Hello and welcome. Thank you for joining us in our Autism for Primary Care Education series. This series is brought to you by the Rich Meadows Division of Family Practice Child and Autism Network, as well as the help with our pediatrician, Dr. Anna Maria Richardson, and collaboration through our Shared Care Committee. Hi, I'm Dr. Ursula Layton, and I work in Maple Ridge, British Columbia. I was one of the project leads in the Autism Project. We had heard from our family physicians, our nurse practitioners, and also our pediatricians that they were really unclear about the assessment and also treatment pathways for children with autism. They expressed a lack of clarity for resources available in our community as well as provincially, and they really wanted to know what best practices would be to support the patients, the parents, as well as the caregivers. With the prevalence of autism rising, it is more important than ever for family physicians to understand and know how to support patients, parents, and caregivers. And I would like to introduce you to Dr. Anna Maria Richardson, a pediatrician that will help us to understand what to do next when we suspect autism. Dr. Richardson is a dedicated pediatrician practicing in Vancouver, British Columbia. As somebody that deals with a lot of assessment for autism, she understands the challenges in identifying, diagnosing, and then actually supporting children with autism. As a physician that does autism assessments, she has a huge understanding of the difficulties when it comes to identifying, assessing, and also managing children with complex behavior needs.
All right, welcome to part two of the presentation series on autism that I'm doing with the Ridge Meadows Division of Family Practice. I'm Anna Maria Richardson. I'm a community-based pediatrician. And so this is part two of three parts. Part one just talked about kind of my thoughts about autism in general. Part two, we're going to go through screening and surveillance. And then part three, we'll talk about what to do after the diagnosis. So quick reminder about what autism is. It's in part one, but just a quick reminder. So autism right now, Autism Spectrum Disorder is defined by the DSM-5, the Diagnostic and Statistics Manual, version 5 TR. And it's under the heading of neurodevelopmental disorders, and neurodevelopmental disorders encompasses intellectual impairment, language disorders, ADHD, movement disorders, communication disorders, and tics. So just a quick refresher kind of on where autism is. And again, the diagnosis itself is based on difficulties in two big categories, in social communication and in restrictive repetitive behaviors. They're clearly laid out in the DSM as you see here. As a primary care provider, you're going to be seeing many, many, many children. There are a number of what we call red flags that should cue you that potentially your patient may have autism. These are it's not a comprehensive list, but these ones are pretty suggestive that you should really investigate a bit more. So, not really talking by 1 year of age, not turning to name by 9 months of age, not having a social smile by half a year, not using gestures such as pointing by 1. By 2 years of age, if words are really still single, if they're chunks, if they're echolalic, again, a red flag. And I think probably one of the most important ones would be any regression in skill. And so very often children with autism will have an autistic regression between the ages of about 18 months to 24 months, but it can be younger to a little bit older. Any regression needs further investigation. So I'm just going to go through just kind of like different things that people may come to you with, parents may come to you with, or different symptoms, I'll call them, that the child may present with. But remember, again, even though I understand kind of how I'm a specialist and I feel like even what I do is too broad, family doctors and nurse practitioners that do primary care, hats off to you. You know everything about everything. So it's just a guide in terms of what to do, who your allies are, what you can, kind of your next steps. So whenever you have one of these red flags, always remember that there's community support. So consider a referral to audiology. Maybe your patient doesn't hear very well. The Infant Development Program is an amazing resource for children under 3. It is self-referral, but you can refer. For Indigenous patients, there's AIDP, Aboriginal Infant Development Program. Every community has a Child Development Center or a CDC. Again, they're self-referral or you can refer. Always remember that you have us as your kind of your allies and colleagues. And then if you do have these red flags, we'll talk about how you screen for autism. So there's some great, easy to use tools that you can use in your clinic. For children 18 to 36 months of age, there's the MCHAT-R. It is a modified checklist for autism in toddlers, revised with follow-up. Make sure you actually pick the right one because this is the shortest and easiest to use. There are 20 questions. They can be filled out by parents. The scoring is simple, 3 to 7, moderate, 8 to 20 is high, and very easy to use screening tool. When kids are a bit older, you can try using the CAST or the Child Autism Spectrum Test. Again, downloadable, parents fill it out, easy to score, and if you're scoring higher, you can refer, and it gives you a bit of a guideline. So who can diagnose autism? The Ministry of Children and Family Development, or MCFD in British Columbia, provides funding for services, and so they have established the guidelines and rules for assessment. Under 6, so up until 5 years, 11 months, and however many days, the assessment is actually a bit complicated, and you need to have speech and language assessment, you need to have a developmental assessment completed by a psychologist, you need to have a qualified specialist do the autism assessment, and you need a pediatrician to do a medical and developmental history. When you're 6 and older, you just need a qualified specialist to do that. And so a qualified specialist is somebody who's done training in the ADOS and the ADIR, which are the tools that we use for diagnostics. And in British Columbia, again, it can be a physician, pediatrician, psychiatrist, or psychologist. In British Columbia, again, in order to find someone who is able to do an assessment, you can either go down the public route, and that would be BCAN, so BC Autism Assessment Network through Sunnyhill. And family doctors, nurse practitioners can refer to BCAN if you have concerns while referring to a pediatrician. The average wait time right now for a publicly funded assessment through BCAN is between 2 and 3 years, and so it's quite long. So that opens up private assessments as another option for families. However, private assessment can be quite expensive, maybe $3,000 to $4,500 for under 6 and $2,500 to $3,500 over 6. So again, it sets up a pretty big inequity. But those are the two options. So there are certain things that people can do while waiting for the diagnosis. And there's 3 websites here that give you some information about what to do while patients are waiting. Autism BC holds workshops. The government website also has While You Wait, What to Do, and ACT. Autism Community Training in BC also has a great amount of resources for families. So don't feel that just because you've referred to IDP or to CDC or to BCAN, you can't do anything. You can give families these websites, and they can do workshops and learn how they can support their kids. I think part of the reason why we have such a complicated system in British Columbia for autism assessments is that the diagnosis in children under 6 comes with $22,000 that the government provides to families to be able to use for therapies for intervention. And this is called the Autism Funding Unit, or AFU. And so under 6, $22,000, and then 6 and over up until 18 is $6,000 per year, with the remainder of intervention going through the public school system. When you're 6 and under, you need to have only specific therapies are approved, and those are found on the RASP, R-A-S-P, Registry of Autism Service Providers through the government. And that includes people like a board-certified behavioral analyst, or BCBA, behavioral interventionist, a BI, speech and language, occupational therapy, and physical therapy. Over the age of 6, it's much more varied what you can use that funding for. And again, it's not money that's given to families, it's money that's held by the government for the child that providers can access. A benefit that people don't, I think, often think about is that 20% of the funding can actually be used by parents for education, for supplies, for if you want to buy, sensory tools for your child, if you want to buy an iPad, it's 20% of that funding. And something interesting is that it actually includes counseling as well for the parents and the family, and those providers don't have to be on the RASP list. So language development is a common concern that parents will come to see you with. So just a reminder, the developmental domains that we look at are going to be motor and gross motor, fine motor, language development, social development, and cognitive. So those are generally what we talk about with the domains. And again, a reminder, global developmental delay is a delay in 2 or more of those domains before the age of 6. After, we consider it intellectual impairment, and that's the difference between those two terms, GDD and ID. So the language domain, and that includes verbal language and sign language, just language, includes an expressive component and a receptive component. And so expressively, it's words or signs that are used to communicate with others. And receptively would be words or signs understood from others. So under expressive, we consider word approximation. So ba for bottle in a toddler is a word. The other thing that we will commonly use is an utterance, and so again, still considered to be communicative language. Parents will often wonder, maybe they're in a 2 or 3 language household, and so they might be worried that is actually causing expressive language delay, but research has demonstrated that it's about a month. It's not more than that. Other things to remember with expressive language is that scripted language or chunks are actually counted as one thing. So Dora the Explorer, that would be 1 word, not 3. All done is 1 utterance, not 2. Thank you, again, 1 word. And so when you're counting them, don't try to divide them up. And then I have quite a few patients that talk up a storm, but it's not communicative. And so they'll be sitting there scripting or talking about what's going on around them or animating toys. And if it's not used to communicate, then we don't consider that to be expressive language. So an isolated expressive language delay. So that's when a child presents and they have difficulty with expressive language, and it's the only domain that is affected. whenever a child comes in with an expressive language delay, just make sure you screen for the others, because you just want to make sure that you're not missing kind of a GDD expression. So this would be a typical, like a late talker. So a child that is doing everything else, is not talking very much. It's about 13% of kids 18 months to 23 months, so quite a few. And then just like most kids with an expressive language delay don't have anything else that's going on that you have to worry about. And so just make sure you screen for the other domains, but if it's an expressive language delay, it will come. Anecdotally, I've found that there's been a family history of expressive language delay, and so I'll often ask the parents, any of you, did any of your parents tell you that you talk late? And it's often, it's inherited somehow. I'm not sure how. So just generally, in pediatrics, I think I think in medicine in general, but I think we have to remember way too many things. So I try to simplify it. So by 1 year of age, should have 10 words. By 2 years of age, so by 1 year of age, should have about 10 words, and 1/4 of unfamiliar adults should be able to understand. By 2 years of age, 50 words, but 2 words should be put together. And they should be able to follow 2-step instructions, and 2 out of 4 people should be able to understand you. By 3 years of age, 200 plus words, 3-word sentences, 3-step instructions, and 3/4 of unfamiliar adults should understand them. And by the age of 3, too, is where they're doing the W questions. So why, who, when, where, all of that. So what to do if you have a child with an expressive language delay? Refer to audiology, IDP, CDC, and think, could this be autism? Just think about it. And if you wonder, you can use a screen. So next topic is tantrums and meltdowns. I listen very carefully when parents are telling me that their kids are melting down, or having tantrums, behavioral dysregulation, whatever word you want to use. Very seldomly, I think, will parents come in if it's not a real issue. So obviously, I will not use the terrible twos. I call them the independence-seeking twos. Kids that are 2 tend to have tantrums, right? We know they do. But when parents come in, it's usually because the tantrums are out of keeping with their chronological age. And when kids are having big meltdowns, I think that really cues me in, could this be autism? Again, not because autism leads to bad behavior, but because there's a mismatch between supports and expectations and what the child actually needs. So these are meltdowns that are really impacting a child's ability to participate in preschool and daycare and school and after school activities. I find that they're generally related as well with difficulty in communicating. The thing that tends to trigger meltdowns are the RRBs in autism, so that insistence on sameness, the hypersensitivity to noises, to sounds, a very restrictive interest. So this is where I tend to think, could this actually be autism? So if you're having a child with pretty significant meltdowns or tantrums, what can you do? So refer again to pediatrics. We can help. This would be the social emotional domain of the developmental domains. And if there's language, again, could this be a GDD? Screen for autism, do the MCHAT or the CAS depending on the age. There's a great phone-based parent coaching program called Confident Parent Thriving Kids that are wonderful for children between the age of 3 and 12. And it's very accessible across the province. Child and youth mental health can provide supports. At the local CDCs, they may have access to supported child development, which is meant to provide support for the child in preschool or daycare. And then there's Kelty Mental Health that has a multiple information and websites and information about different mental health issues, and one of the ones they have is around tantrums and meltdowns. So, and then parents can actually find a lot of benefit and support from talking with peers, and so the Family Support Institute is quite wonderful for peer-to-peer support. The BC Council of Families has peer-to-peer support as well, and community services as well. So you can provide supports for parents as well as for the child. Another common issue that really makes me listen when parents come in is when they tell me that their child is not sleeping very well. So just a reminder that in general, between the age of 3 and up to 3 months, kids are mostly sleeping 14 to 17 hours per day. Between up to a year, 12 to 15, 3 to 5, 10 to 13 hours, and it just kind of goes down from there. So in pediatrics, the difficulty with a child that doesn't sleep well is the impact on the family. Because if the child's not sleeping, then the parent's not sleeping. And as a parent, you have to parent, work, and take care of the household. And that can be very tiring when you are not sleeping as well. So sleep disorders, I very much listen when parents tell me that their child is not sleeping. And to me, I need to think, could this be autism? Sleep disorders are way more common in children with autism, 50 to 80% compared to 25 to 40% of the neurotypical peers. And the sleep difficulty tends to be more persistent, so it doesn't go away. The two main categories for sleep problems are difficulty in falling asleep, so sleep onset, and then difficulty staying asleep, sleep maintenance. So for sleep onset, you need to think about, could this be restless legs? Could it be associated with that be iron deficiency? Myoclonic jerks can sometimes wake up kids, and then a bunch of behavioral. Bedtime routine, fears, transition, just some kids don't ever want to go to sleep. Things that can impact sleep maintenance are going to be parasomnia, so things that happen while you're in sleep, sleep waking, sleep talking, sleep walking. Night terrors are quite common, bedwetting, eczema, and then again, behavioral or anxiety. The other thing is enlarged tonsils or adenoids, so snoring can disrupt sleep. So things you can do, there's a standardized questionnaire to make sure you're kind of addressing all things called BEARS. You can screen for BMI, for obstructive sleep apnea, screen for eczema, which can be quite impactful of sleep. You can look at behavioral interventions, routines, setting that up, quite beneficial for a lot of kids. If you're having difficulty with sleep onset, so falling asleep, melatonin can be really helpful. There was a recent health advisory in February of last year in the States that said it's not unsafe to use, but just use safely. And so I recommend the lowest dose possible. I have families that will use 1/4 milligram of melatonin, and that's all their kids need. The other thing that you can try, just kind of as a potential benefit, would be treating for enlarged adenoids. And there's a recent study that said that in intranasal corticosteroids and intranasal normal saline were almost equivalent in preventing referral to ENT. And so try intranasal normal saline. It's over the counter, very safe, and it might actually be quite helpful. So I think I mentioned this in part 1, is the picky eating, and I'm talking really picky eating. So again, my independent seeking 2-year-olds want to pick what they eat, and they can be quite picky. So picky eating is common in all toddlers. So 20 to 25% have some type of picky eating. There's no definition, they're just picky. Studies have looked at toddlers and they've identified that over the course of a year, 30% of toddlers will be picky at one point in time, but only 5% will be picky at 3 points in time in that year. So again, it's a persistent pickiness. There are other things that will for sure contribute to picky eating. Things like if there was a NICU, a neonatal intensive care unit stay postnatally, maybe there's feeding difficulty there. Food sensitivities and allergies, oral motor function problems will contribute to picky eating. But generally, in a neurotypical toddler, it disappears and kind of goes away on its own. In 80% of neurodiverse toddlers, it is persistent. And this can be a variety of the neurodevelopmental disorders, not only autism. And again, be mindful about ARFID. I have families that, like, I've got a family that, their school-age child will only drink formula or, only take goat milk or, it is incredibly picky. When a family tells you that their child is picky, try to gather a bit more information. ARFID, again, is when it develops into disorder and you end up with weight loss or you end up with nutritional deficiencies because of the picky eating. So what you can do, it's hard. This is a really hard one because ideally every child would have access to a pediatric registered dietitian to help. But they're quite hard to access. I believe different communities have different access to an RD, and be mindful that a registered dietitian is very different than a nutritionist. An RD is a 5-year university degree, whereas anybody can call themselves a nutritionist. So if you are having significant pickiness, screen for autism. Again, you can consider referral to the local child development center. Occupational therapy and speech and language can do an oromotor assessment, and maybe that can be helpful. There are some websites out there in terms of how to increase diet variation in toddlers, but again, it's for neurotypical kids in general. HealthLink, BC, and Kelty have information about what to do with picky eating. But the interventions for a neurotypical toddler versus a neurodiverse toddler are different. So if it's really not working, then again, consider screening for autism. Toileting is another very common, I don't want to call it problem, but children with neurodevelopmental disorders will have difficulty learning how to toilet. And it's not just toileting, it's constipation, it's irritability, gut irritability. There's a huge relationship between GI symptoms and autism. There's a big meta-analysis completed, and I think children with autism experience significant GI symptoms compared to control groups. And we're talking, the big ones are going to be abdominal pain, constipation, diarrhea, food intake issues. The other things that you have to consider are pica. And so children with autism will often either mouth things for sensory, like their sensory seeking behaviors, or iron deficiency, and they're actually eating rocks and soil and picking at the walls of the drywall. And then families, and I am a believer in the gut-brain connection and the gut metabolome contributing to overall health. And so there's a big relationship between gut and autism. So things we can do if you're worried about iron deficiencies. So if you're engaging in eating non-food items, so check a ferritin, always check a CRP with that. And the goal for children with neurodevelopmental disorders is to have a ferritin over 50. And the The so what about ordering investigations is always what I think about, because if you have a picky child and you've identified iron deficiency, getting iron into them is going to be an equally challenging problem. So I am a firm believer in any iron is better than no iron. And so the goals for pediatrics for iron replacement are going to be 3 to 5 milligrams per kilo. But if a family is able to get 1 milligram per kilo in, half a milligram per kilo in, that's better than nothing. There's a whole bunch of other formulations as well available. Generally, I'll recommend families just go to a local pharmacy or vitamin supply store and see what options are available and see what you think would actually be most tolerable for the child. I think even in the States right now, they're developing an iron patch. So it's a big issue. And again, iron is going to cause constipation, it's going to cause GI upset, so you're going to have to manage that as well. For constipation, PEG, Restore Laxaday is a really fantastic over-the-counter treatment. It is expensive for some families, prohibitively, but I usually will start children on PEG with the iron. You want to prevent constipation because that becomes a whole other problem. So I usually, again, start really low and increase is tolerated. If you start too high, kids end up with diarrhea and parents will just stop it because they don't want diarrhea, which is fair. The other thing I tend to add is senicides. And so again, you can, low doses at night can be really, really helpful. I usually start with a quarter cube of senna, which is 4.3 milligrams, and work up from there. You don't want side effects, you want it to be effective. So I mentioned about pica. So another common issue that parents will come to you with is sensory issues. And so eating things that aren't food, but kids with autism are either hypo or hypersensitive. They're seeking sensory input or they're avoiding it. And so sensory seeking, as mentioned, licking things, sniffing things, touching everything. Maybe they'll be peering and dropping things in front of their eyes or throwing things repetitively to hear them, to hear the noise. Kids will be upside down, watching TV, like with their feet in the air. These are all examples of sensory seeking behaviors. And so the opposite would be very common, like earmuffs. Parents will say, I can't take my child to the public bathroom. They'll have a meltdown. And it's because the toilet flushed without anybody flushing it because it's all automatic, or the hand dryer comes on, which is super loud. Parents will say, I can't use a blender, I can't use a vacuum. Crowds of people might be overwhelming. Kids that don't wear jeans or tags, or parents are ordering socks from Germany because they're the only socks their child will wear. Like, these are all very, they're very unusual behaviors. And so just keep an ear out for them. The best support, I think, for sensory behaviors is occupational therapy for children. And so occupational therapists, pediatric occupational therapists focus on sensory regulation. They're quite wonderful. And so either privately or through the local child development center. And then again, if you're having the sensory meltdowns with sensory things, or, very sensory seeking, screen for autism. And that's it for part 2. Thank you very much, and hopefully you'll join me for part 3.
Dr. Richardson, we really want to thank you for dedicating your valuable time and for giving us so many resources and valuable information that we can share with patients in our practice. Please join us next time for a final installment for the Autism in Primary Care Education series. With this installment, Dr. Richardson will help us delve deeper into what to do after autism is diagnosed, as well as some very valuable tips on how to set up your office for success when patients come and visit you with autism. If you have any questions with regards to the Autism Project or the Autism Toolkit, please reach out to the Division of Family Practice. We hope you enjoyed the series. We thank you for watching, and we hope to see you soon.